Hi, everyone. Thanks for joining. We're just going to give a couple more seconds to give others some time to join before we start. So my name's Matt. I'm from HR.com. If you are joining us for the first time today, welcome to day 2 of Inspire, and welcome back to those that have rejoined us. Have a look around and tune into the valuable learning sessions and networking times. Check out the event navigation guide to get the most out of the event. I'll post a link to the exit survey in the chat area, and the presentation slides will be available in the archived version of this event on hr.com. If you have any questions during the sessions today, simply add them in the Q&A on your webinar controls, and there will be time for live answers at the end of the session. You will also notice the chat feature, which you may use to engage with attendees and panelists. We always love to hear your comments. The session today is Manage Plan Risk and Diabetes Costs with Effective Plan Design, now and post-COVID. It's now my pleasure to turn it over to George Huntley, who will lead the session. George.
Thank you, Matt, and thank you, HR.com, for hosting this event today and the Inspire Conference, and welcome to everybody who's joined us today. We're glad you're with us. I am pleased to, if I can get the slides to move, forgive me, guys. There we go. I'm pleased to introduce myself and my co-host and partner, Aaron Turner-Phifer from JDRF. We're delighted to be with you. Aaron, why don't you introduce yourself briefly?
Sure. Aaron Turner-Phifer, Director of Health Policy at JDRF. For those that don't know, JDRF is a not-for-profit focused on improving the lives of those living with type 1 diabetes and ultimately finding a cure for type 1 diabetes. And we do that through global funding of research across the world on cures and therapies that improve type 1 diabetes.
Super. And I am George Huntley. I'm the Chief Executive Officer of the Diabetes Leadership Council. I'm a patient living with type 1 diabetes for over 38 years. I'm a past national chair of the American Diabetes Association. And in my day job, I'm also the Chief Financial Officer of a professional services firm based out of Indianapolis, Indiana. And in that role, I have been the plan administrator of a self-insured employer-based health plan for over 20 years. So I have that employer-based experience as well as the patient experience. The Diabetes Leadership Council is a 501c3 nonprofit that's focused solely on advocacy and policy advocacy on behalf of patients with diabetes. Everybody on our board is a former national leader of a national level diabetes organization, and we're just delighted to be partnering today. So really quickly, we'll walk through our goals and objectives. First is to understand how diabetes impacts your employees and how it drives your overall health plan risk and costs. Hopefully learn a little bit on benefit design from some folks that we're going to be talking to today, and both medical and HR side, and take away some key plan design features. So we're hoping that you've got some tangible ideas by the time we're done today's presentation. The way we're going to go through it, and we're going to go as quickly as we can because we're going to put this into 50 minutes. We're going to go through a session on state of diabetes care and coverage, and that Aaron's going to lead us through. We've got a medical panel as well. Then I'm going to talk about marketplace dynamics that are influencing the diabetes care and costs, and specifically pharmaceutical costs. And then we're going to have a special panel discussing HR perspectives and plan design, and we're going to talk to Demmy with Ford Motor Company, and it's going to be a very interesting conversation about what Ford is really doing on behalf of people with diabetes. And any questions that come up during this time, feel free to put them in the Q&A, put them in the chat, and we can go from there. Without further ado, I'm going to let Aaron walk us through the state of diabetes.
Thank you, George. And let me just start by saying, I'm excited. I think George and I are both excited that you all are here with us today. Rare is it that there's an opportunity that presents itself to improve the lives of your employees, but also save money in the process. So we're excited to share some of these learnings with you all. And just quickly, 1 in 8 adults, and nearly 34 million Americans, according to the CDC, are living with diabetes today. That doesn't include the nearly 200,000 kids and teenagers that may also be included in your plans that are also living with diabetes. Nearly 1 out of every $4 that we spend on healthcare in this country goes toward diabetes. And this is supported by recent studies showing that diabetes is one of the top 4 leading cost drivers for large employers. We suspect that this is true across insurance categories. And let's move ahead to the next slide and we'll see why that's the case. The nature of diabetes itself is chronic and progressive, which means that unmanaged or poorly managed diabetes can result in more serious complications, which have a higher price tag and ultimately impact bottom line. Needless to say, they also produce poorer health outcomes for folks living with diabetes. The result of some of these complications can be diabetic retinopathy, heart disease, kidney failure, lower limb amputation, all in degrees of significance higher than general population. The good news is that with effective benefit design and support, folks living with diabetes can effectively manage their care. And so not only producing better health outcomes, saving money at the end of the day. And so we'll jump over here to the next slide before we welcome our provider panel and just talk a little bit about the rates of diagnosed diabetes. And one thing I want to highlight here is that the prevalence of diabetes between type 1 and type 2, most people with diabetes today are type 2. Type 1, the distinction is that type 1 is an autoimmune disease, meaning folks with type 1 diabetes their body simply doesn't produce insulin, and so they need insulin to live. There are folks with type 2 diabetes that are also insulin dependent, but one thing I want to highlight for folks is that the prevalence of kids being diagnosed with diabetes, they tend to have type 1. And so for folks, your employees and folks enrolled in your plan, this risk category, especially amongst kids, is going to be significant. And so I want to highlight that distinction because even if you don't have an employee with diabetes, if they have a child with diabetes, that can be a significant, not only financial consideration for them, but also a stressor as they're relating to their work. There's a disproportionate impact on communities of color as it relates to diabetes prevalence. You can see here the degree and rate of diagnosis amongst different race categories with a nearly double rate of diagnosis amongst Native Americans and Native Alaskans compared to non-Hispanic whites. So one last point, since we are in the time of COVID, over the last year, it's been revealed that folks living with diabetes do have a higher risk of severe complications should they get COVID. And so that's certainly something to be aware of as we move forward and try and balance providing better care to folks in post-COVID reality. So with that, as a kind of state of play, we'll jump to 2 of our distinguished guests we have with us today. Dr. John Anderson from the Nashville area and Donna Ryan joining us from Florida. Welcome, welcome. Thank you both so much for being here. I think, John, you got lucky. We're going to start with you, and maybe you can just tell us a little bit about your background and your practice.
Yeah, thanks, Aaron. My name is Dr. John Anderson. I practice internal medicine and diabetes at the Frist Clinic in Nashville, Tennessee, part of an HCA group. So while I am a diabetes expert, I also do primary care. So I'm a primary care physician. So in addition to diabetes, I see all of the other acute and chronic diseases.
Excellent. And Donna, why don't you tell us a little bit about yourself, your background, and your practice?
Yes, hi. My name is Donna Ryan. Thank you for having us today. And I'm the Regional Director of Community Health and Diabetes Programs at Ascension, Florida. We have 5 hospitals and a very large medical group across the Gulf Coast and approximately 10,000 associates. I'm a registered nurse as well as a registered dietitian and a certified diabetes care and education specialist.
Excellent. And we are so excited to have you both provide a little bit of background and maybe get under the hood a little bit about what it's like to live with and try and manage diabetes. And so Donna, first question to you, what are some of the key elements that are required to be successful to manage diabetes?
Well, diabetes is a patient-managed disease, and people living with diabetes manage their condition 24/7. So successful self-management includes having the tools and resources to help them stay healthy and to manage their blood glucose. There are tools such as technology, which is huge in the diabetes space with insulin pumps, as well as continuous glucose monitors and medications.
No, I think, and I think, George, if some here in the next couple of minutes, pull up, I think, the chart showing all the different areas that someone with diabetes has to consider as they're managing, their care. I think that would be helpful. And so, John, I'm curious about, based off of kind of what Donna laid out around, the things you need to be able to have success managing diabetes. What are some of the challenges, maybe getting access that you've seen in your experience, folks getting access to those tools and therapies?
Yeah, thanks, Aaron. Well, first of all, everybody with diabetes is an individual, and they're as different as any patient sitting from you. So there is no one size fits all for patients with diabetes. But when they're diagnosed, they need access to education. Our diabetes educators, our dietitians, maybe exercise specialists. We at the American Diabetes Association say we really need a team approach. They may need access to PharmDs. And so it's really important that on the front end, patients diagnosed with diabetes, whether it's type 1 or type 2, have that kind of access to education. And then at different points in their continuum with diabetes, they may need education again. And as Donna said, they need access to the durable medical equipment, the monitors, the continuous glucose monitors when appropriate. They need access to insulin. There are a bunch of different categories of medicines for type 2 diabetes that also have cardiovascular benefit. And some of these are expensive. But the cost of diabetes is on the back end with complications. And so we really need to be thinking about what we need to manage this disease on the front end.
And Don, so that makes me, I'm curious about your perspective, across a region in Florida that you cover. What are some of the maybe challenges that your folks have experienced, navigating their insurance and benefits, getting access to many of the medications and therapies that John mentioned?
Great question. And as wonderful as the modern technology is and the medications are for helping people manage their diabetes and keep their blood sugars in control, there's also challenges with affordability and access to them. Co-pays, deductibles, and the ability to afford these devices and these medications monthly. Even with insurance, it can be costly. We had a patient recently who could not afford all of the cost of care for his medications, and told us that he confessed that he rations his insulin so that it will last longer, so he doesn't have to buy it as often, and he will even alternate his cardiac meds with his diabetes meds on months that he has to use his money with something else. And this is very unfortunate. It's really an access and an affordability issue. The insurance literacy is huge. A lot of people annually run into that January bucket where formularies and medications change, and it takes catch up to understand what has changed and to be able to access the new formulary. So there's a lot of work to be done here.
Right.
And I think that's an interesting perspective. And we had a survey of our folks that is coming back now, and I think most folks tend to stay with their same insurer year over year, but the change in benefits year over year, even if they're with the same health plan, tends to put up barriers. So, and John, I'm curious, just from your experience, what are some of the things in plan design and insurance coverage that prior auth, non-medical switching, what are some of the things that you've encountered that are in essence artificial barriers that can sometimes hinder access to care?
Right. And so at the beginning of the year, if you have a high deductible plan, then everything is being paid for out of pocket. And, if you have type 1 diabetes, insulin can be expensive, pumps can be expensive, continuous glucose monitoring can be expensive. In type 2 diabetes, remember that people with type 2 diabetes are usually on a statin medication for their cholesterol. They're on 2 or 3 or 4 medications for their diabetes. They're on 2 or 3 antihypertensive medications, right? So as Donna's point, even copays that may be something like $50 you don't think about, by the time you've accumulated enough copays, it becomes a staggering amount. The issue of non-medical switching literally drives me crazy. You will have patients who will have, say, an SGLT2 inhibitor. It's a class of medications that work through the kidneys. Well, they go to their pharmacy late January and find out it's not covered anymore. They may have gotten a notice that says it's not covered but they don't tell them what's covered. Then my nurses have to try to figure out what's covered. Sometimes, they'll get back, well, they'll cover metformin. Well, we've been on metformin, right? So what happens is these patients go without medicine for 3 months. If I have a patient who is on an injectable and they live 40 miles away, they're mad, they don't have their medicine. I see them in March, 2.5 months later, and their A1C is completely out of control. Their diabetes is out of control. And there's been nothing proactive to be done about this non-medical switching that drives us crazy every single January.
I see you nodding your head along there. Do you want to jump on the non-medical switching?
Yeah, the amount of time and energy on the healthcare professional side is, as Don said, huge. On the patient and family side, there's this medical literacy. People are struggling with names of meds and following these complicated or simplified self-management plans. And then on top of that, they have to figure out this rubric of what insulin can they afford now? What can they take now? How they have to call the doctor, they have to call the pharmacy, and they spend a lot of time. And to be honest, a lot of people don't spend as much time as we would as healthcare professionals because they don't understand the system as well. And we have people that show up and they just haven't been taking their insulin for 3 months. For 3 months, they haven't been taking their fill in the blank, their fast acting or their half their basal dose. And that's why their A1C goes high. And then we do have to do the detective game of where and how did this happen. And it goes right back to their plan was upset and changed, and they didn't know how to navigate the changes.
And Aaron, to Donna's point, it's not just about they've been off the medicines. They're off the medicines and they had an emergency department visit for a complication that could have been avoided, right? And that's where the real cost is. So when we start talking about, trying to find and navigate a way for patients to have access to all they need, realizing that the upfront costs of making sure that happens is far less than what we see in terms of emergency department visits, hospitalizations, complications further down the road. I mean, there's a real investment return by making sure patients are stable on the front end.
I think that is so much of what we hear from folks who are living with diabetes is wanting to be proactive, needing to be proactive, and trying to navigate sometimes the Byzantine system and trying to make sure that you're not choosing between food for the family and your prescription. I want to close on a broader point around one of the things that's important to us is kind of the not just the patient with diabetes, but also the family and the support that is required of them. And we encounter it a lot. It's not just type 1 though, or young people with diabetes and how that impacts the family. So I'm wondering if each of you, as we close here, can just kind of reflect on your experience of the magnitude of energy that's required from someone to manage their diabetes and the support system that's required, and broadly how easing this path around benefit design can help support that and enable that to happen.
Donna, you want to jump in first, or you want me to do this?
Yeah, I'm not sure. I think we're going to say the same thing. I'm not sure where to start, other than the burden is huge, and employers have a huge opportunity here to lessen the burden on the family, the amount of time, whether it's a pediatric, a child with diabetes, or a grandparent with diabetes. And we see this growing number of 20 and 30-year-olds with diabetes. It takes the families to support them, and it takes a lot of time. So a lot of this technology is helpful in lowering that diabetes distress that we have with the 24/7 of the lows and the highs and the medical emergencies. Getting a solid plan that they can afford and that they can and that they have access to makes a huge difference, not just on the person and their A1C, but on the entire family unit and their support system. John?
I can't say it any better. We say in the American Diabetes Association, and George knows this, when a child gets diabetes, the entire family gets diabetes. Okay, this is a family disease. We have technology now where parents can safely monitor their children as they go away to that transition phase in college that we didn't have before. We have ways of keeping patients safe. And to Donna's greater point, the ability to decrease the temperature in the room and relieve the stress and because it's not fun having type 1 diabetes. It's not fun for the family. It's not fun having type 2 diabetes, but anything that you can do that improves safety, improves care, relieves the depression and the diabetes distress that we all see, both with the patients and the families.
Well said. I really appreciate both of you taking time to share your experience and walk us through a better understanding of what it is to live with diabetes and to treat someone with diabetes. So Donna and John, thank you so much for being here. And with that, I will turn it back over to George.
Thank you.
Thank you.
Hey, thank you, Aaron, and thank you, John and Donna. Excellent presentation and discussion, and very true. Every bit of it, very, very true. So I'm going to shift this over to talk about some marketplace dynamics and things that are going on to influence the care and the costs that your employees, their plan participants are experiencing, and you in the plan are also experiencing. So let's start with insulin. Insulin is the drug that's getting probably the most news today, as far as if you have type 1 diabetes like I do, you need insulin to live. Without type 1, without insulin, the person with type 1 dies. About 1/3 of your patients or participants with type 2 diabetes are also on insulin. So insulin is not a drug that is just for type 1 diabetes. They're literally roughly 1/3 of your plan participants with diabetes are likely on insulin today. So what's going on with the price of insulin? Well, the price is going up at the list price level. So on the right-hand side of the screen, you see list prices are rising, and I'm going to show you a little bit that over time in a second. 1 in 4 patients are reporting rationing of their drugs, and you do not want to ration insulin. Bad things happen when you ration insulin, people, including tragic deaths. But the weird thing from a marketplace dynamic is competition is rising, and when competition rises, prices typically fall in a free market society. So we've got at least 3 brands that are out there making insulin. There's at least 2 insulins of every class, fast acting, long acting, et cetera. But list prices are going up. However, net prices are in fact going down, which does make sense. So on the left-hand side of the equation, the marketplace dynamics are working as one might expect them to work, but it doesn't translate that to retail price at the cash register at the pharmacy. And that's really what's frustrating patients who are not protected by this. And there are biosimilars on the marketplace, and there are not yet authorized generics, although I think a couple of the brand names came out with generics of their own product to lower list price. So we've literally got some brand names that came out and just relabeled their existing drug and launched it at half list price, and none of the formularies picked it up. So chances are none of your plans cover the half price version of the drug, because the net price didn't change with regard to the cost of that drug. So a lot of weird marketplace dynamics. And if you're asking where this money where these numbers came from, this is me buying insulin in Noblesville, Indiana in February of this year, at the beginning of my plan year, if you will. Fortunately, my plan passes through rebates, so I only paid $85, which is still too high. I need to work on my plan, but it was a lot better than paying $334. The other thing to be aware of is most people with diabetes are going to need 2 or perhaps even 3 vials of insulin a month. So this isn't just, oh, here's $334 for 1 vial of insulin. If you're on multiple daily injections, you're taking a long-acting and a short-acting insulin. And in many cases, type 2 patients are more resistant to the insulin, and therefore they need higher quantities. So this is, it's not unusual to pay a lot more, and we'll talk about that in a second. So let's follow the rebates here. This chart shows the shift of list price in the blue at the top and net price in red at the bottom from 2012 to 2020. And you can see how list price has gone up 141% over this time frame, now cresting over $300. whereas net price peaked in 2014 and has actually dropped over the last 7 years. And that is what you would expect the marketplace to do when there's competition in the marketplace. But the insulin rebates can exceed 70% of the list price. So basically meaning the price of insulin is inflated by 70% on that list price. And that is not just insulin, that's along all of brand name drugs. It's about 48% of the price is inflated with rebates. Now, what are rebates? Rebates are access fees to get access to the formularies. So the pharmaceutical company is paying back these rebates as an access fee to your pharmacy benefit managers, your Express Scripts, your Caremark CVS, your Optum RX. Those three control about 75% of the US market, those three. And chances are most of you are using one of those three, but statistically speaking, at least 1 in 4 of you probably aren't. But they've got a lot of power in the marketplace. You have to pay in order to get access to the formulary. And if the plan design isn't protecting the patient from that list price, you're literally inflating that cost by hundreds of dollars. Now, where do those hundreds of dollars go? Well, those hundreds of dollars go through to the PBM. The PBM is keeping a slice of it and then sending the balance of it back to you. So you, if you're a self-insured employer, are getting, if this is a $235 rebate in the midst of this, you're probably getting $200 back when your plan participant buys a vial of insulin in January. So they have subsidized the rest of the health plan, which is really reverse insurance. You've got the sick subsidizing the healthy if you are not passing that through to them. And that's really not how insurance is really designed to work. It's designed to have the healthy subsidize the sick so that the burden is shared, if you will. So let's talk about the plan designs here. These are 4 very real plan designs. I'm sure everybody on the audience recognizes these scenarios. On the far left, first dollar preventive coverage. If are you treating chronic disease pre-deductible as preventive care, which means you are bypassing the deductible, even in a high deductible health plan, you are allowed to do that. It's a may, not a must. And so a $0 cost share. There's a CVS Caremark actually has a plan of 0 RX, which they've done from an insulin perspective because it is cheaper to give insulin away than to pay for the complications. $25 a month, a low predictable copay. No one's going to complain about a $25 copay for a drug, and you're going to find that your participants adhere to their therapy, which is what you really want them to do. Then you start getting into the right-hand side of the column where you are in a cost co-insurance during that deductible period, but in the $360 version, you are at least passing through the rebate. So the patient's paying $360. It's more than many can afford, but $360 is far better than $1,200. And $1,200 is a very real scenario for a patient who is on insulin and is not getting any relief from a rebate pass through at the point of sale. And that patient is very likely to be rationing their drugs. And they're your highest risk person on your plan, and you'll probably give them away a pedometer to help promote walking. You'll give them an apple in the lunchroom when there's no COVID. But if you charge them $1,200 for insulin, you are really raising their risk level significantly. So let's go to the first poll question here. Does your organization offer at least one plan with full rebate pass through to your plan members? And do you even know? I mean, many of you may not know. So please go in and check the box, and we'll see what the audience poll says. It takes a minute for everybody to click the box. It's like watching a pot boil. All right, so this matches what we saw on a similar presentation. So 23% or 21%, excuse me, are saying yes, that they are passing through rebates at point of sale. 43% are not passing through rebates at the point of sale, and 36% were honest and said they're not sure. And that's actually not abnormal for folks to not be sure. So hopefully by this presentation, this is something we urge you to take a look at and learn what you're doing and what you're really exposing, because these are your plans. You can design these so that you're paying for the things to manage the disease and not for the emergencies that arise. So thank you for responding there. So one of the takeaways here is please manage your pharmacy benefit managers like a vendor. They work for you. You do have the ability to negotiate these, and many times you don't realize that you do, but you actually do have the ability to negotiate these. And do you in fact know what rebates you're getting, and are they the right numbers? And the large employers with a large staff are able to figure this out. But many of the smaller or mid-sized employers don't. I remember when I first started getting rebates as a plan administrator, it was manna from heaven. It was, oh, here's a check for $40,000. Well, thank you very much. What's it for? Well, I'm really not sure, but here's $40,000. I have no idea whether it should have been 50 or whether it should have been 36, but I got a little extra. But here's $40,000. Thank you very much. See you next year. But this is real. This is real money. And I do urge you to take control of it and understand it. It also leads to perverse incentives. And we talked about non-medical switching. And the pharmacy benefit manager has an incentive to put the higher priced drug on your plan because they are taking a cut of these rebates. So the higher the price of the drug, the bigger their cut is. And so if you are not managing this process, you will not necessarily get the lower cost drugs on your plan. And when these biosimilars hit the market and some of the other generics hit the market, whether it's insulin or other drugs, this is across all of the pharmaceutical classes. The pharmacy benefit manager has an incentive to not put the low cost drug in there. And the other piece I will say is your employees know if they're getting charged list price or getting overcharged for their drugs, and it's going to lower their trust in your plan. So our ask and our recommendation for plan design features, very simply, pre-deductible coverage. Diabetes management is preventive care. It's far cheaper than paying for the complications. And if you look at your diabetes costs, they're driven from the hospitalizations, not the drugs and the devices and the supplies. Low predictable employee cost sharing, spread that cost throughout the year, make it affordable so that they can adhere to their therapies and manage the disease. Rebate pass through, eliminate the rebates, list price exposure, and pass those rebates through at the point of sale during the deductible period. That's really when this really impacts things. And then the last thing on this is treatment choice. And we didn't hear a lot about that, but there are multiple versions of insulin pumps. There are multiple versions of continuous glucose monitors. There are multiple versions of blood glucose glucometers. There are just multiple versions of things that allow, and each of them are help the patient manage their therapy in the way that suits them. And this is a disease that the patient is managing 24/7, 365 days a year, and they're seeing the doctor for about 20 minutes 4 times a year. So a lot of that time, the patient is on their own. Give them the choice that they've got the tools that they need and they ask for. So we're going to launch to another poll question. Does your organization offer at least one plan with first dollar coverage? Is treating chronic disease care, diabetes care, pre-deductible? So please answer this, and it's a may, not a must. You may treat this in a high deductible health plan pre-deductible, but you don't have to. And we're here to try to encourage folks to see that this is actually in your best interest to do. And we'll wait for the results of this survey. I know you're all sitting on pins and needles as I am. and survey says, I've always wanted to say that, survey says, 38% yes are treating it pre-deductible. That's fantastic. 38% also are not. So it's about split there, and 23% don't know. And I would encourage you to take a look at that. And I encourage all of you to take a look at that, because chronic disease care is chronic diseases are a lot less expensive if you cover what they need to manage the drug, manage the disease. It's just a fact. And you can reduce your plan risk by doing that. So let's talk about reducing our plan risk. And I'd like to introduce Demmy McBride. It is my pleasure. I'm getting to know Demmy in preparation for this. And Demmy leads the U.S. Health and Welfare Benefits at Ford Motor Company. She's also serves in a leadership role on Ford's global well-being team. She joined Ford in 2015 and has 19 years of healthcare industry experience. Prior to Ford, Demmy spent 13 years at Truven Health Analytics, now IBM Watson Health, serving as the account executive for many large employer clients, both public and private. So Demmy, welcome, and thank you for being with us today. Appreciate you being here.
Thanks, George. Happy to be here.
That's great. Could you share with the audience a little bit about the health plans that Ford Motor Company offers, and just give us an overview of things?
Sure, I'd be happy to. So we have about 90,000 employees in the U.S., and of that number, approximately 2/3 are hourly employees, and about 1/3 of them are salaried employees. And they are two very, very different populations with different plan designs, and you think about the two populations differently. So our hourly plans are collectively bargain plans with the UAW. They are extremely rich, platinum level plans, no premiums, effectively no out-of-pocket costs under the plan design. They just have very, very low copays for just a couple of things. However, on the salaried side, we have gone what in the industry we call full replacement high deductible health plans. And we believe them to be very, very attractive plan designs. We went to a full replacement high deductible plan strategy very thoughtfully. They're designed with simplicity and value to the employee in mind. And by that, I mean, our most popular high deductible health plan, we have two of them, and about 2/3 of our salaried employees are enrolled in one of them that has it's a $0 contribution plan. So it's a free plan to have. It does have a higher deductible, but the thought is, instead of our employees sinking their costs into a high premium, which is how our plans used to be when they had lower out-of-pocket costs, we would rather them take that pre-tax money out of their paycheck and fund an HSA, invest in themselves. Then that way, if they need the money during the year to pay for their healthcare services, they have it. And you know, employees who have, or plan members who have diabetes or other high cost conditions are going to, need to use their HSA. But those that don't have a condition or don't have expenses in the year can really hold onto that money and save it for the future. Our philosophy is we want our employees to invest 100% of their dollars into themselves as opposed to sinking them into premiums. So I'll get off of that for now. And so if you like, George, I can start to talk about diabetes. That would be fantastic. And that's a great
segue into that. And it's a unique approach to the $0 premium to allow folks to put money into HSA. So hopefully folks are taking notes on that. And yes, please do share how you're handling diabetes management.
Sure. So as I described, there's quite a few differences in our hourly and salaried populations, but there's some similarities as well. And diabetes is a condition that impacts many employees under both of those populations. So we have about 8% of the members in our hourly plan, so members means employees plus dependents, have diabetes, and about 6% of our salaried members. And that number of patients increases every year, primarily on the type 2 diabetes side. Diabetes is our most costly chronic condition, and it's in the top 3 to 4 conditions overall every year, in the mix with low back, depression, and hypertension. So a number of years ago, probably 3-4 years ago, we decided that we were going to do a deep dive into our diabetes data and explored a number of different innovative strategies to help our employees and their family members who have diabetes better manage their condition. So after reviewing a number of different options, we decided that the single most important action that we could take, and I mean this both from the plan member, the employee, the dependent's perspective, as well as for the company, the most value for our investment was to remove barriers for this population to remain compliant with recommended care. So we want them to stay compliant with their medication regime, their insulin. We want them to take advantage of the great tech that's available in the diabetes space, you know, the devices that you described already, the pumps, continuous glucose monitors, et cetera. And so one thing that we could do that was easy was open up access to diabetes supplies and even vaccines recommended for diabetics under the prescription drug benefit in addition to the medical benefit. And so this provides our employees and plan members with wide access to different products for diabetic supplies and devices. We want them to have choice and ultimately convenience. However, another concern is the cost barrier, and I think you guys did a really good job of teeing up that issue, because these medications, insulin, the devices are expensive. And so while we don't really have cost barriers for our hourly plan members, the high deductible on the salary side of the benefit definitely concerned us, even with the $0 monthly contribution. And so we at Ford believe in a concept that's called value-based insurance design, sometimes, you know, abbreviated as VBID, VBID. And this is the idea of using the plan design to encourage the use of high value medical services and basically things like preventive care, primary care visits. We want folks to stay compliant with recommended care for their condition. However, the IRS regulates what types of services and medications are allowed to be covered at first dollar or pre-deductible in a high deductible health plan. So there was a really momentous date, you know, back in July of 2019, where the IRS updated its guidance, and it allowed plan sponsors like Ford, who have high deductible health plans, to cover medications and supplies for patients with chronic conditions, including diabetes, but not exclusive to diabetes, pre-deductible. And we were waiting for that to happen. And as soon as it did, we jumped on the opportunity. So it was at that point that we launched, and it took us a few months to get, it's a 1/1 of 2020, we'll say, we launched something that we call our Value RX list for managing chronic conditions. And so this helps not only diabetics, but people managing other types of chronic conditions. And the idea is that we cover diabetes medications, insulin, devices, and supplies at first dollar pre-deductible. And we, as you can imagine, got incredible feedback from our employees, particularly our employees who they themselves or their family members have chronic conditions like diabetes. And, you know, it was the right thing to do, right? We want them to have a high quality of life. We want them to be healthy. However, it was also really the right thing to do for the company financially. We know the theory, I guess I'll say, is that the upfront investment will benefit the plan in the long run. So if employees are better managing their conditions like diabetes and staying compliant with their medication and their treatment, they'll have fewer costly complications down the line. The doctors addressed that on the first panel: avoidable emergency room visits, hospitalizations due to complications, et cetera. So I'll just pause there. I could go on and on.
Yeah, and I think as we spoke last week and you were sharing this, Steve, I think the comment I gave you was, do you have any job openings? Because I'd like to apply. It's great coverage, and you're doing the right things. And I want to just stress for the employers out there, because that July 9th of 2019 release from the IRS, the guidance that they said that you now can cover chronic disease care. We were talking, JDRF and DLC, we've been partnering for several years now. We've been talking to large employers, and it was about half that were saying, yes, we're going ahead and doing it anyway, and half that were waiting for the IRS and to do this. And it was pretty interesting to see, okay, finally, as a patient advocate, we finally got through and the IRS and the Treasury and the HHS got together and came out with common sense guidance, because it's just, whether it's diabetes or any other chronic disease, it's just not good for the patient, and it's really not good for the plan to not cover. So have you seen any changes, or how do you track, the employee experience, whether it's absenteeism, presenteeism, those kinds of things? What's been your approach there?
So we have been planning since the time that we decided to make this change. We're a very data-driven company. I came, as you heard in my bio, I came from IBM Watson Health. I have a healthcare data analytics background. We partner with IBM Watson Health today. So we've been talking to the researchers at IBM about basically designing a study that will help us evaluate the long-term impact of this investment we're making in pre-deductible coverage. And it is not as simple, unfortunately, in the short term of just kind of tracking prescriptions and, fill dates for insulin. I mean, ultimately, I think what it boils down to, and I'm sure the doctors could describe this much better than I could, ultimately, it's all about control of the disease or control of the condition. We don't have access to the HbA1c rates for these patients. And so improved outcomes, so if they're getting their condition under better control, that might mean that they need to, for example, test less frequently. There may be less variability. It could result in changes to the medications. And so we don't want to kind of artificially attribute a trend, or in the last year, even the impact of COVID on the plan design, to something that we did. So we're playing the long game here, designing a study. When we have enough data under our belts, we're going to take a look at improvements in control rates, the risk scores, and ultimately hope to see reduced or slower progression of diabetes and related comorbidities, to see fewer complications and flare-ups, and ultimately less cost. But I'll have to get back to you down the line.
Well, we may take you up on that and call you back for a future date. But I honestly thank you so very much for sharing some of the most excellent coverage options that you've got for your employees. And kudos, hats off to you and to Ford Motor Company for how you're approaching chronic disease care. Thank you so much for being with us.
You're very welcome.
Thanks a lot. I'm now going to shift us back to wrap us up, because we really only have 2 more minutes here in the show. Plan design key features. This is pre-deductible coverage. Hopefully we're knocking this one into you. Low predictable employee cost sharing, rebate pass-through, treatment choice. But there's some other features that I would also have you focus on as we wrap here. Continuity of care. This is the non-medical switching. Changing a stable patient's regimen every January is not in the plan's best interest, nor is it in the patient's best interest, but it is in the pharmacy benefit manager's best interest, and that's why it's happening. So they're getting a higher rebate for a different drug, and the net cost of those drugs don't change very much at all. But if you're not grandfathering your employees to this, that is something that they're being exposed to, and you may not be paying attention to that. So that is something that you should be thinking about as you're looking at your plans. Rapid adjudication of diabetes-related claims, or any related claims. Let's talk about step therapy. I think John spoke about it briefly. You get a patient that's on a drug, SGLT2, which is, I'm not going to tell you exactly what it is, but it's a type 2 medication. And then they now join your plan. So they're a new employee, and they've been on this drug for a while, but your plan has step therapy that says you must start with metformin and fail on that drug. Well, they've been on the drug that's working for them for probably 4 years, and now you're making them. So if you have step therapy protocols built into your plan, you could be forcing that patient to take a massive step back. So please take a strong look at that in your programs. Spread on generics. Metformin, which is the common drug to start with in type 2. It costs $4 at Walmart. But if your plan's charging $20, your employee knows that, and the extra $16 is going to your PBM. It's not going to you. Some quick takeaway steps, and we're at the end here. take a look at your plan, and you can download all of this information, but there's ways to analyze your data and your plan costs. There's ways to look at how much are you spending on prescription drugs versus hospitalizations or other major claims, because that's where your real costs are, and they're probably not being labeled diabetes. They're probably being labeled heart attack, stroke, kidney, renal failure, things like that. But diabetes is likely, an uncontrolled diabetes is likely driving it. So take a look, really dive into what's going on here. This is not just managing your medical costs. This is managing a lot of other things as well. So thank you so much, Aaron. Thank you for being with us. It's been a pleasure partnering with you. Aaron and I will be at the booth, at the JDRF DLC booth. If we'll have a live chat immediately following. If you do have any questions, we'd love to talk to you about it. Please download the slide deck and some other takeaways. There's a 2-minute survey. We urge you to take that so we can learn a little bit more about how you guys are doing your plans. And just thank you for being part of this today. Really appreciate your attention.
Okay, thank you to George. Thank you, Aaron. Thanks to Demmy, Donna, and John for joining us today as well. Very informative. We always appreciate that. Thank you to the sponsors, Diabetes Leadership Council and Juvenile Diabetes Research Foundation. Thanks to you, our attendees, for attending today. Your feedback is important to us, so please take a moment to fill out the exit survey that will open in a new browser page on your computer. We'll be sending you an email with the credit information, and you'll also find the credits on your View My Credit page of your membership profile once the webcast has been archived. This concludes the webcast session. We hope you've been enjoying Inspire 2021, and all virtual booths are available for the entire event as well as the networking lounge. So take some time to look around and connect. Thank you, everyone, and have a great day.